Okay. This second talk is one of my favorite topics. We are going to speak about bone viability with spect bone scan and with PET with fluoride. Any of you, do you know when the indication of bone viability for bone scan has been described firstly? No? Well, in fact, it was at the end of the 70s in a French hospital I think it was in Grenoble, and they described the bone scan to determine the level of amputation in feet and hands. And it seems that it continues to be the best technique to decide which is the level of perfusion and which is the level of a good amputation, not to have to go to a second amputation. Okay, we are going to see some images. The main indication for bone viability are, for example, on the left, a child with amputations after a sepsis, and with a question about bone viability on remaining bones. And in this case, we can advise the traumatologist if they have to re-intervene with the surgery the child or not. Or on the right, you can see some images of a PET with fluorine for the follow-up of revascularization surgery in case of femoral head osteonecrosis. Do you perform here in Kuwait the free vascularized bone graft, the traumatologist, the pediatrician in pediatrics or in adults? Yes? Okay. I am going to show you some images about this technique, which is frequently used in my hospital for osteonecrosis or also for reconstruction after bone tumors. And the bone scan gives us an assessment about the bone viability in this kind of interventions. In this case, for example, we have in a child a bilateral femoral head osteonecrosis secondary to treatment. I think it was a child with a previous leukemia with a long-term treatment with corticoids, high doses on. And on the bone scan, you can see here is a collapse on the left femoral hip. And here is not a collapse, but there is an area of osteonecrosis. In these cases, you know that the prognostic of these hips is very bad at the age of a young adult, and the orthopedist tried to do something. Okay, and the things that they try to do is a complex surgery that consists in a free vascularized fibrillar grafting, a substitution of the necrotic bone in the femoral head by a healthy bone in order to increase the perfusion and to prevent the collapse of the femoral head. This is the surgery. On the left, you have the image before surgery, the magnetic resonance image before the surgery, and here, after the surgery, they make a hole through all the femoral neck, and they put on this hole new bone for the femoral head, and they put a vascularized fibrillar graft. This is the technique in detail. The necrotic area is removed through a tunnel in the lateral face of the femur, and the gap is filled with healthy bone of the iliac crest, and after that a graft from the fibula with the artery of the fibula is placed on this tunnel, providing mechanical and biological blood support to this pathological area and making local vascular anastomosis. And what are the problems for the orthopedist after that? This is a case with a bilateral surgery. The problems that they have is that they want to know if this graft is vascularized and if there is a regeneration of bone in these femoral heads. Immediately after the surgery, the clinical question is the femoral head perfused or not? And is the bone viable or not? This is a right hip which has been intervened just 2 weeks before the bone scan. And the question, as mentioned, is there is a bone graft viability? Is there a perfusion of this? And here on the spect images, what are you seeing? On the planar images, you can see an increased diffuse uptake of all the femoral head. But this is normal because the child has surgery just 2 weeks before. And you can see also an increased uptake on the iliac crest, bilateral, more markedly in the right side. And this is also due to the recent surgery. And looking at the spect images, what can you see here? You can see the fibula, and we can see the femoral head. And where is the higher activity? The higher activity is on the wall of on the cortex of the fibula, and this is due because just 2 weeks before, this fibula is supporting weight, and for this reason, this cortex continue to have a high uptake. But look at the end of the fibula here. It seems that there is a little bit of increased uptake on the new bone placed on the femoral head. That means it's a good prognostic. Okay, and well, our report is the perfusion is okay, and it seems that the osteogenic activity is beginning to increase. And what about the left side? The left side has been intervened 6 months ago. Okay, and here, where is the higher activity? Where? In the fibula? No, on the femoral head. Yes. And this is a good prognostic? Yes, this is a very good prognostic. This has been one of the first cases intervened in our hospital, and now the orthopedists are very, very happy with the technique and with our follow-up, and they are now trying to intervene these children or these adolescents before the femoral head collapse. Okay? Because then the prognostic will be better, and we will have a revascularization and osteogenic activity of the femoral head before collapse, with a good congruence between the femoral head and the acetabulum. But we are no more doing this technique anymore. What are we doing now? Now we are performing a PET with fluorine to value the bone activity in these cases and to better detect bone lesion in some special cases. Look at this case. This is a recent case on the left and on the top, and you can see in a young woman a reperfusion on the left femoral head, but in this case without a fibular graft. Here the technique has been just a forage through the femoral neck. On the right side, they perform just a forage without anything, and just the trauma can stimulate the bone neoformation. And on the left side, they perform the forage, plus they inject stem cells. Which side do you think has a better prognostic? The left side, with the injection of stem cells. Okay, this is a clinical trial. Is a new technique, and it seems that the forage plus stem cells will have a better value for the treatment of these patients. And compare the quality of the image of the PET with fluorine compared to the bone scan. It's really different, not? This is a girl, a 70-year-old girl. When she was 13, she had an Epstein-Barr virus with an hemophagocytic syndrome. And after that, she developed a femoral head osteonecrosis. On the left, you can see the PET with fluorine, the whole body image. Where are the abnormalities? What can you see? There is a volunteer. What about the femoral head? The left one is normal? No. We have a cold area on the left one, and on the femoral, on the right one, there is an increased, yes. And what about the radiography, the X-ray film? There is a fibular graft, okay, and there is an increase of uptake in the femoral head. That means a good prognostic, okay. But if you look at the whole body PET scan, what about the foot, the feet? There are areas of osteonecrosis also on the distal part of both tibias. Okay, and after this, these areas have been treated, but I don't have the image, with stem cells, with punction with stem cells. Okay, this is another case. It's not a boy. It's a male, 37, but with beautiful images. For this reason, I am going to show you. In June 2008, he has been diagnosed as having a bilateral femoral head osteonecrosis, but without collapse. 4 years later, he comes to the hospital with a left hip pain, 1 year of evolution, and on magnetic resonance imaging, he was diagnosed of a grade 1 on the right and grade 2 on the left. He entered in a clinical trial, the same that I mentioned before, and he had a forage on the right hip, and 1 month later, forage plus stem cells on the left hip. Okay, and we perform the PET 1 year later, and this is the PET with fluorine, of course. What do you think? Which femoral head is better, the left one or the right one? The left. Those who received the stem cells injection. Okay, some more images. These are the comparison in this clinical trial. They perform systematically every 3 months, I think, magnetic resonance imaging in order to detect early the bone regeneration. But they fail, and they decide to stop the magnetic resonance image because they detect only bone abnormalities, but not early regeneration like the PET scan does. Well, here you have a comparison in this image. You have the PET, the CT, and the MRI, and here you have the PET and the CT. And you can see very easily that the bone regeneration on the left hip with the stem cells is much bigger than on the right side, 1 year after the technique. And here again you have the whole body and the hip, the femoral head images, and you can see on the axial images that the left femoral head is much better than the left one. Just one picture about Lecques-Calvé-Perthes disease. On the acute phase, as mentioned before, we can detect the cold area with or without an external pillar, like in this case, the external pillar manifest a better prognostic and a lower percentage of femoral head collapse than the children without the external pillar. And also I have one beautiful case about sickle cell disease. In these cases, we perform the bone scan with whole body blood pool images in order to detect the areas of inflammation, and sometimes we perform white blood cell scintigraphy. Here on the right, you have the blood pool cells images of the whole body here, and the bone images. In these cases, we prefer to obtain spot images because the spot images have a higher sensitivity and a higher resolution of the images compared to the whole body images. In fact, because the children is closer to the detector. Okay, a volunteer. What can we see on the blood pool image? It is normal? No? What about the pelvis? Is this pelvis iliac bones symmetrical? No. We cannot see the left, no? And here on the feet, there is an increased uptake in the blood pool here. Okay. And now we go on the planar images of the bone uptake. We can see the spleen, because in fact it's an acute infarct. What about the vertebra? Very heterogeneous, probably due to previous infarcts in these bones. And now the pelvis. Very asymmetric, with big cold areas, probably due to acute infarcts. Okay. And what about the legs? Femurs? Femurs are very heterogeneous, yes? And the feet? You have an increased uptake in this calcaneum. Okay. It was a suspicion of osteomyelitis because the child had fever, and you know that the sepsis by salmonella is quite often in these children. Then we perform a white blood cells scintigraphy, and these are the images. Here you have the blood pool phase of the bone scan. Here the bone scan, and here the images with white blood cells labeling with technetium. What do we see with the leukocyte scan? What about the pelvis? Hot or cold? Cold, congruent and cold. Okay, that means that probably there are only infarcts, but no infection. And what about the right calcaneum? Hot. That means that we can suggest that it was an infection there. Okay, we can suggest them. In the follow-up, the child came again 2 years later with another crisis of drepanocytic red cells. And now, what happened? We found new infarcts in the vertebra and recovery of the pelvic infarcts. Okay. Osteosarcoma, another topic to value the bone viability. This is a child diagnosed firstly of a proximal right femur osteosarcoma in a very advanced stage. This is the planar X-ray, and this is the magnetic resonance image. And in fact, the osteosarcoma doesn't theoretically affect the acetabulum, but it was in contact with the acetabulum. That means that after chemotherapy with good response, and they operate the child with a salvage surgery to try to maintain the extremity, and they did a technique named en bloc extraction of the acetabulum. That means that during surgery they remove all the acetabulum, they went with this acetabulum to radiotherapy. They irradiated this block, and they put again all this block on place on the iliac bone. Of course, with vascular microsurgery. And they question, just 10 days after the surgery, if this block is viable. And what do we perform? In this case, just a bone scan, but the bone scan had the answer to this question. What do you think? Is this bone, this irradiated acetabulum, viable or not? Can you see bone uptake on the acetabulum? Yes. Look. This is not working very well. Huh? Well, there is an uptake on all this acetabulum. It's very well seen on the posterior view. And performing a bone CT, you can see there is an artifact due to the metal of the graft, but you can see very well the uptake on this irradiated bone. And that means that they done the things very well, and they vascularized very well this graft. Okay. On the coronal images, we can see also very well the uptake. In fact, with a little bit of displacement of the femoral, of the graft, of the femoral head, but well, this is not important. And after Ewing sarcoma of the mandibula, they also, after the chemotherapy, sometimes they put on place also a bone graft, and they ask us also about the bone graft viability of this new mandibula. And here on the spect CT images, you can see the left part with the own mandibula with the teeth, and on the right part, the bone graft, and the bone graft is completely viable with bone uptake. And now we go to PET or PET CT with FDG or with fluorine. This is one case of a young woman of 27 year of age with infection in the right foot after a car crash with multiple open fractures. She received treatment with antibiotics during more than 2 years, and 3 skin grafts failed to be viable despite of all these antibiotic treatments. Okay? Can somebody tell me which is the tracer on the left and the tracer on the right? On the left, which is the tracer? On the right is fluorine. It's easy because you can see the bones. And on the left, what is the tracer? FDG. FDG to see the infection. And well, here you have only the MIP images, but you can see then with FDG there is a big deposit, and with fluorine you can see increased activity of several bones of the foot. The question of the traumatologist is that he decided to make a partial amputation of the leg, and he wanted to know the level of the amputation, because it seems that the tibia can also be involved. Okay, and now we are going to try to answer this question. These are the whole body images and the image of only the foot. And here you have 3 images. The image of the here, okay. This is the fluorine uptake. This is the blood pool phase of the PET just after injecting the fluorine. We inject the fluorine on the camera, on the PET CT device, and we obtain one bed of 2 minutes or 1 minute, in this case it was 2 minutes, just after the fluorine injection. And here we have the blood pool phase. And look at this image, it's very similar to the image obtained with FDG, because here we have all the inflammatory process before the bone uptake. Okay? And here we have the FDG image. If you see at the localized fused images, here you have the images with FDG, and here the images with fluorine. Here we can detect the areas of osteomyelitis, and here we can detect the areas of infection. And what the traumatologist decide? He decide to make a tibio-astrogalen amputation because the bone uptake on the tibia was nearly normal. Okay, and this girl has been operated 1 year ago, and she's safe, and she's very, very good. Another case. This is one boy, 4 years, with meningococcal sepsis when he was a baby, with multiple amputations. For example, he has no legs, and he has a left arm shoulder arthrosis, perhaps due to what is the name? The sticks, with pain on the left arm, not on the right one. And the traumatologist is asking us for a PET with fluorine to value if a part of the left radius is viable or not. One cause of bone pain is that there is a persistence of one segment of bone without perfusion. This can provoke pain. And in this case, the PET is supposed to answer the question and to decide if he has to resect this part of bone or not. Okay. Here you see the planar image with superimposition on the right, or the MIP image on the left. And here on the left, you can see the blood pool image in order to see the inflammatory process here, you can see. And in fact, it was an inflammatory process on the shoulder arthrosis. Okay. And on the right, you have the MIP images, but it is very complicated due to the existence of multiple fractions of bones in this arm. And I think that you can see much better in the fused images. This is the right arm without pain, and this is the left one with pain, and the shoulder arthrosis here. And here you can see the fused images of the blood pool phase. What can we see here? We can see an inflammatory process around the shoulder arthrosis and nothing else. And here on the delayed bone uptake images, you can see that the supposed non-vascularized segment of the bone here, it is viable because it has big uptake, and the biggest uptake is in the area of the shoulder arthrosis. That means that this child has not to be intervened to resect the bone, but he has an important shoulder arthrosis which causes this pain, and it's quite difficult to manage without legs and with the sticks for life. Okay, and to the end, I would like to invite you to the 9th edition of the European Symposium on Pediatric Nuclear Medicine, which will take place in Girona, in Platja d'Aro, next May from 5 to 8. And one of the invited lectures will be about bone viability with PET fluorine. Thank you very much.